Thanks so much, Lorenzo. So that was excellent. Could all three speakers put on their cameras, please? So we've had a number of questions through. So I'll sort of start with Sarah. So basically, there are a couple of questions that are a bit related. So one was, were you surprised at the findings, that how similar the Gypsy traveller population were to the general population? And was that what you expected? And then you partly addressed this, but use in the sorts of studies that we are all doing is not the same as need. Was overall use in general practice lower than the general population as well, which might indicate underuse for mental health?
Right, okay, so I'll take the first question. So were we surprised? Not really. I think we didn't really know what we would see. So we knew from previous studies that there were significant issues around access. So we did anticipate that actually some of our rates might be even lower, even though the underlying need might be higher. We weren't surprised by this pattern with a greater contact with emergency services. We were expecting to see that. And again, it wasn't clear the degree to which we would actually see that in the data. And I think this kind of feeds into the second question as well, is that use not being the same as need. We don't know to the extent to which people are not presenting at all, or presenting only at the point where things are reaching crisis point, and choosing those services accordingly as well. So is there a resistance to present at a GP practice because there's difficulties registering, or because there's fear of discrimination or being stigmatized, and also some resistance within the community about mental health as a topic in itself as well. So some of the things I've been reading have been suggested that it's considered to be quite a stigmatized topic, much more associated with more severe types of mental disorder. So some of the issues around things like anxiety and depression may skirt under the surface and not get addressed at all. So I don't know if I've managed to address both of the questions at once then.
I think you have. I think a couple of the interesting conversations that came up when we were talking to sort of service users and people who work with the community was some of them were saying that the level of sort of social cohesion within the group might mean that the things we expect about mental health may not necessarily be true. And where do you know when you trust the data or not? And I guess the other thing is going back to that stigma in this community. We've had a project funded by the MLC, an engagement project, where we've worked with refugee and asylum seeker young people, Gypsy traveller young people, and young people with mental health problems. And the resistance to engaging with a project about mental health was much higher in the Gypsy traveller community than in the others, which wasn't what we were expecting. So it's interesting. So Aideen, a question from Dermot, I think, but it might be copied and pasted from someone else. Is it possible that social services don't put some children and families on their books if their workload is too heavy?
Oh, that's a leading question. Is that from Dermot O'Reilly?
It might be from someone else, but I guess it really, you could all think about it. It's how much do we trust our routinely collected data? Is basically, it's all about strategic behaviours and labelling.
Absolutely, and I think that's vitally important whenever we look at trends. When you're looking at trends of the numbers of children in care in Northern Ireland over the last 30 years, it remained fairly stable for about 20 years, and it's increasing now, but only ever so slightly. We're talking, an extra maybe 100 children per year, and there seems to be a standard level of there are enough foster carers and places to care for about 3,000 kids every year, and that's it. So is the level of need increasing, but there just aren't enough foster carers and placements there to look after children? Possibly. There's no sort of indication from the data that would, rate a child and be like, if we could place them in care, we would, but we can't. So we're going to return them home as a child in need with a care plan. And I think that would be much more informative for us to know in terms of what need is, and is need actually increasing. But by all means, all we can ever trust from the data is what we can see from it, and remember that it's collected for service provision purposes, it's not for research, so it's not always going to be perfect.
Thank you, very true. A question to all of you, but Lorenzo, you can have first shot at this one. So a lot of us are working with observational data in observational studies, and thinking particularly, about risks and risk assessments. So on the one hand, our findings show that the right risk groups are being identified, or do they show that our interventions aren't working? Can we ever unpick that in the sorts of studies that we do? So like a good example would be maybe 4 or 5 years ago, I'd be contacted by the press a lot about how admissions for self-harm in children were increasing and how terrible that was. And until we had the data from sort of probability sampled surveys that yes, actually self-harm in young people was increasing, I was sort of going, well, we can't really say, because it could be that we're just adhering to NICE guidance better and admitting children. So what are your thoughts on that and the sorts of studies that we do? Lorenzo, I'm going to go to you first.
Well, I guess, yes, in part, I think it's it's a problem that's difficult to unpick. But at the same time, I think working with real data, with clinical data, you work with real data, and I think the kind of index that you go to assess are really important to then plan future actions. So I think by analyzing existing trends and then we can plan future intervention, future actions. And I think part of this issue that you were mentioning, I think it's unavoidable, but I don't think there's a better way of doing this.
Anything to add, Aideen and Sarah?
I can just jump in. Sorry, Sarah, I'll just jump in quickly. And I think I agree with everything Lorenzo said, but I think what's important then, whenever we're working with administrative data, is to work with people on the ground who actually are in charge of inputting this data. And the reason, for example, that we may see increases in self-harm presentations or admissions, if we go and talk to the doctors in A&E who may be able to then give us the information and say, you're right, our policies changed 2 years ago and we do this. So I think it's vitally important not only just to look at the data in isolation, but to look at policies that have been out around recently and talk to the people who generate the data to try and understand better the trends, not just at face value.
And I really think that's a two-way street. So absolutely what you're saying is vitally important for the people working in services and for the people using them, that we engage with them. But also, and like in COVID, anecdotally, we were really getting messages back that on the ground, self-harm attendances had increased. And when we looked at it, but at a national scale, what we saw was that drop that we saw in everything. But the proportion of self-harm contacts had increased, which I think is where that impression was coming from. So I guess it's a three-way street, isn't it? Patients, practitioners, us, trying to unpick those findings. We've had a general question through. So from Doretta Karmanishki. So is the data that you use available for secondary analysis? And how easy is it to access them? So what's fascinating about the three of you is you're using 3 different systems from 3 different nations. So we always couldn't have planned this better. So I'm going to start with Sarah.
Sure. Sure. Yeah, so the data that I've used for my study are available, both in general and actually specifically as well. So in the study specifically, the list of residential anonymous linkage fields would be possible to be made available to other studies on application to SAIL. More generally, the data sets that underlie the study were available from the Adolescent Mental Health Data Platform. So for studies where there's a focus on adolescent or children and young people's mental health, you can submit an application to the Adolescent Mental Health Data Platform. For research areas outside of that, you can do the same to SAIL, and there's a very clear application process. I'm just looking at your question as well. I can see you asked about costs as well. There are some costs involved. Neither organisation are for profit, but there's costs involved for covering things like infrastructure and then support from specialists, either from SAIL or from ADP as well. But if you're interested, we can share the application process to you so that you can see that.
Thanks, Sarah. Aideen?
Yeah, quite similar to Sarah there in that the data set that I've sort of created and linked isn't available by itself, but the underlying data sets are available for you to apply for and access yourself in any sort of combination. And there's a range of other health and hospital data sets available as well. Now they're made available via the Honest Broker service in Northern Ireland, which is slightly similar to SAIL in that they take in all of the information, anonymize it and make it available to researchers. And recently, thanks to COVID actually, the Honest Broker service now has a secure research platform, so a similar platform to SAIL, where the data can actually be accessed remotely. It used to be that you had to physically go into the safe setting to access the data, but now pushed forward by the wonderful COVID pandemic, remote access is available, so hopefully it'll be made much more available to guys across the UK. Again, if anybody's interested, you can drop me an email. I'm happy to give detail about that. There is a small nominal cost with preparing these data sets, but they tend to be around £2,000 or £3,000, not very much.
I mean, that's a huge transformation, isn't it? Remote access. That's great. Lorenzo?
Yeah, so all the data we used in aggregated form are publicly available in Scotland. So the prescription data comes from the Scottish Primary Information System, and well, the other data comes from the Scottish Morbidity Records, and these are in aggregated form, are freely available. The specific data we analyze are kind of extracted from this kind of public registers and are relative to the subjects that participated in the study, and they came to us in anonymized form, so with kind of codes to identify the subjects, but no other identifying information. I'm not entirely sure. I would have to read the kind of you know, the specific conditions attached to this data to find out whether you know, it's possible to pass on these details to other researchers, but in generally speaking, you know, it is possible to apply through various governance routes. It is possible to apply to gain access to the data, and as the other speakers, I would be more than happy to provide more indication about how to do that if you drop me an email.
I guess one of the things that's really important in this sort of accessing the data and people not having to start again are the principles that we all abide by, of sort of code lists being made public and algorithms, you know, to create. So in ADP we have incidence and prevalence algorithms, so things where you're reusing the concepts that you've created, so that the next person who comes to maybe look at a slightly different question but with a similar data set can get there much faster. And I think that principle of mental health data science is really important. A question for you, Lorenzo. Were there any considerations for determining that those without data from the linkage was still healthy compared to getting rid of them in your cohort?
So yes, so essentially, yes, as I said, you know, there was a number of subjects didn't appear in any of the databases. Now, we actually gave a lot of thought about this, because if we had taken away the subjects from the analysis, we would have selected a sample that would have essentially, we would have selected the seeker subjects that, of course, were present in the database because they access healthcare. So overall, we thought we would have introduced a bias if we did that, while keeping the subjects that didn't appear in any databases and assuming they remained healthy, essentially avoided to introduce this bias. Of course, it is possible that other biases have been introduced by this, but bias is, I think, is unavoidable in research, and you have to kind of acknowledge what kind of bias are at play, and draw your conclusion based on that. We did run some of the analysis in a kind of, how would the data change if all the subjects that didn't appear in any of the database became unwell, versus how would the data change if all the subjects that didn't appear in any of the database were excluded, and how would they change if they all remained healthy? So we did run some of the analysis, different scenarios, and generally speaking, the kind of general trends didn't change much. So they changed a little bit, but not by much. So overall, we considered that the best solution was to consider all the subjects that didn't appear in any of the database as having remained healthy, because we thought there was introduced the least amount of bias.
Thanks, Lorenzo. So we've run out of time for any more questions, but there are loads more, and I think that's always a sign of a really good session.